Okay, good evening, everyone. My name is Mariam, and I'm the Education Manager for the ERN-EuroBloodNet. It is my great pleasure to welcome you on behalf of the ERN-EuroBloodNet to the second webinar of the topic on focus on constitutional thrombocytopenia. This series is an accredited European online educational program targeting health professionals organized by the ERN-EuroBloodNet in partnership with the CRPP, the French Reference Center for Inherited Platelet Disorders, and the Filière MHEMO, the French Constitutional Bleeding Disorders Network. The program consists of a cycle of 15 webinars developed in collaboration with 3 experts, Professor Marie-Christine Alessi and Dr. Prof Saultier from Assistance Publique-Hôpitaux de Marseille, a member of the ERN, and Dr. Mathieu Fiore from CHU Bordeaux. Our goal with this program is to disseminate up-to-date knowledge among interested hematologists, internists, pediatricians, and other healthcare providers to give visibility to cutting-edge advances in the field of constitutional thrombocytopenia. Before we start, please note that the session is recorded and will be uploaded on the EuroBloodNet e-learning environment. If you do not wish to appear, please turn your camera off and change your name on the platform. Also, please be kindly informed that your microphone is muted. If you have any questions about the presentation, please write them in the chat. They will then be addressed during the Q&A session at the end of the webinar. You can access the chat by clicking discussion or chat on the bottom of the screen. As mentioned, this program is accredited by continuing medical education points issued by the European Body of Accreditation in Hematology. You can request 1 credit per session or 15 credits if you follow the whole program. To request those credits, simply make sure your name and surname are visible on the platform. Then fill out the attendance survey that will be linked in the chat. I will send that during the presentation. And finally, answer the 3-question short satisfaction survey that you will receive after the webinar. So today is the second webinar of this new series. Please join me in welcoming Professor Maria Luisa Lozano, who will lead this lecture entitled Suspecting Inherited Thrombocytopenia. Professor Lozano is the Associate Professor of Hematology at the University of Murcia, an attending physician and head of the Hematology Oncology Department at the Meseguer Hospital, and director of the Regional Blood Bank of Murcia, Spain. She's also a member of the Rare Diseases Networking Biomedical Research Center, and Professor Lozano's research interest lies in the area of inherited and acquired platelet disorders and cellular therapy product collections and processing. Professor Lozano, the floor is yours.
Thank you very much. It is my pleasure to be here today to talk about inherited thrombocytopenias, which, as we know, is a group of disorders in which our knowledge on the pathophysiology has increased substantially over the last 2 decades, but in which the misdiagnosis rate is unfortunately still high. So, I'm sorry, but see now. This slide shows my disclosures. Okay. So the learning objectives of this webinar are first to become familiar with the major types of inherited thrombocytopenia and their verbal presentation, to try to avoid misdiagnosis of inherited thrombocytopenia, especially with immune thrombocytopenia, and to emphasize the need to recognize and investigate those forms that predispose to other diseases, because the early detection of these disorders will facilitate the appropriate follow-up and the treatment of our patients, donor selection for hematopoietic transplantation, and optimal genetic counseling of affected patients and their families. But what is the situation of inherited thrombocytopenias in 2023? At the beginning of this century, we knew of a very limited number of disorders, all characterized by severe bleeding tendency. Now, at present, the spectrum of these disorders has expanded to more than 45 different entities that are caused by mutations in different genes that result in disorders with varying degrees of clinical complexity and a very wide variability in their prognosis. We will not discuss the complex syndromic phenotypes associated with thrombocytopenia due to chromosomal defects caused by aneuploidies, that is, changes in the number of the chromosomes or deletions. These conditions are usually diagnosed very soon after birth because they are relatively easy to identify because of their early extrahematological manifestations. So what is the prevalence of inherited thrombocytopenia? We don't know, but these disorders are being recognized more frequently as the advanced sequencing technologies become more commonplace in clinical scenarios. Exome sequence data from more than 125,000 individuals shows that the overall frequency of the predicted loss of function variants affecting genes involved in inherited platelet disorders is approximately 3 in 1,000 individuals in the general population. So inherited thrombocytopenias are now classified not by size, not by mode of transmission, but by the clinical presentation into 3 groups. Those forms that are characterized by thrombocytopenia alone, disorders in which the platelet phenotype is associated with additional congenital defects that are already present at birth, that is the syndromic forms, and those characterized by a predisposition to develop additional disorders during life. Low platelets are a very common cause of referral of patients to the hematology department. The first step in the evaluation of thrombocytopenia is to determine whether the symptoms or the laboratory findings are significant and they warrant further testing. We should perform a complete clinical evaluation of the patient, including a personal and family history of bleeding, of consanguinity, and inherited thrombocytopenia should be suspected in patients with a family history of thrombocytopenia, myelodysplasia, leukemia, or other phenotypes that raise suspicion, or a family history of mucocutaneous bleeding, regardless of the platelet count. Also, when bleeding is not proportional to the platelet count, such as spontaneous bleeding with platelet counts above 20,000 per microliter. In case of thrombocytopenia that has been classified as ITP, as immune thrombocytopenia, that is refractory to treatment and for which no prior CBC is available. And also when von Willebrand disease with a mild decrease in platelet counts is considered as a possible cause of bleeding. And although in the vast majority of congenital disorders, the degree of thrombocytopenia remains stable throughout life, there are exceptions such as gray platelet syndrome, in which thrombocytopenia progressively worsens with age, or thrombocytopenia with absent radii, in which platelets may spontaneously recover. In almost 50% of the cases, these conditions are associated with additional disorders of or a propensity to develop these disorders that are usually more serious for patients than bleeding itself. And the examples of such disorders include hematological malignancies, bone marrow aplasia, skeletal malformations, hepatic or renal dysfunction, and deafness. Some syndromic phenotypes associated with inherited thrombocytopenia may be clinically variable within the same family with identical genotype, probably due to the fact that rather than being monogenic conditions, other variants may modulate the phenotype and cause digenic or oligogenic disorders. So bleeding can be highly variable, and we need tools to quantify it. The one developed by the ISTH has been validated in von Willebrand disease, but in the field of inherited platelet disorders, they can be of value only for identifying patients with inherited platelet disorders due to defects in platelet function. However, this bleeding tool is not informative or predictive of inherited thrombocytopenia in the absence of platelet defects. Now, distinguishing between defects in platelet number or function is not straightforward, and there is often overlap. While the disorders to the left of the vertical axis do not involve thrombocytopenia, they are exclusively platelet dysfunction. Those below the horizontal axis do not show abnormalities of function. They are only low platelet counts. Of the 42 inherited forms of thrombocytopenia shown on the slide, approximately half are inherited thrombocytopenia with coexisting functional defects that predict a more severe bleeding phenotype for any given platelet count. And now we move to the general evaluation of biological features, including platelet counts, platelet volume, immature platelet fraction, blood smear, and other blood cell subtypes. Now, we know that people with platelet counts between 100 and 150,000 per microliter do not necessarily have a hematological disorder, and there are about 6 to 7% of the normal population with platelet counts in this range. But increasingly, new non-syndromic, mild inherited thrombocytopenias are being described that fall within this 100 to 150,000 range that are often associated with elevated mean platelet volume, and we must question whether they should really be considered a disease. In addition, patients with mild thrombocytopenia and increased bleeding should always be tested for basic coagulation studies. The next basic tool to consider is platelet size. A mean platelet volume of more than 12.4 femtoliters has a high sensitivity and specificity for differentiating inherited macrothrombocytopenia such as MYH9 and Bernard-Soulier syndrome from ITP. Significantly small platelets are the hallmark of a limited number of thrombocytopenias, including Wiskott-Aldrich syndrome, FYB-associated thrombocytopenia, and RPC1B-associated thrombocytopenia. But platelet size can be normal in a variety of inherited disorders. As for the immature platelet fraction, both ITP and inherited thrombocytopenias, especially those with macrothrombocytopenia, have an elevated IPF. So this parameter can only help distinguish them from acquired bone marrow failure. Abnormalities in other cell lines may be present in approximately 50% of cases and may provide also some clues. These include abnormalities in neutrophils, in red blood cells, eosinophilia, pancytopenia, or dysplastic features or blasts due to hematological malignancies. Peripheral blood smear is always very helpful in narrowing the differential diagnosis. And decreased platelet staining suggests an alpha granule deficiency. And light microscopy can confirm the pathognomonic findings, such as inclusion bodies in neutrophils, which are present in most cases of MYH9-related disorders. Immunofluorescence performed on blood smears evaluates certain proteins that will or will not be labeled with specific antibodies, and it can unequivocally be useful in certain diagnosis. But this topic is going to be addressed by Dr. Reinacher in the upcoming webinar, so we will not discuss it. Now, after the basic studies, some more specific tests can be performed, such as platelet aggregation, flow cytometry, or electron microscopy. These techniques are of much greater value in platelet dysfunction than in thrombocytopenia. The high-throughput sequencing techniques that are applied to the diagnosis of these conditions are mainly targeted sequencing of already validated genes, also whole exome sequencing, and more rarely whole genome sequencing. Each method has its advantages and disadvantages. With targeted sequencing, the percentage of unclassifiable cases will remain very high, and we will not be able to identify new genes. The disadvantage of the exome and genome is the difficult analysis and storage of the data, and the intronic variants will be detected by genome analysis. Currently, with advances in analysis and price reduction, we are moving towards exome or genome sequencing, initially evaluating known specific genes, and with the possibility, if the results are negative, to perform a reassessment of variants in other genes. In those disorders that present with thrombocytopenia alone, where severe bleeding may be infrequent, the real challenge is to distinguish these cases from ITP. A patient of any age is much more likely to have an acquired form of thrombocytopenia, since only approximately 10% of the patients presented with a chief complaint of low platelets have any form of inherited thrombocytopenia. The most common misdiagnosis, as we said, is ITP, a condition that lacks a gold standard test. To avoid this, it is of utmost importance to evaluate the patient's previous blood counts and those of other family members. Important clues to inherited thrombocytopenia are the chronicity or the duration of the symptoms, and a greater tendency to bleed that would be expected from the platelet count. In patients with suspected immune thrombocytopenia, failure to respond to typical ITP therapy is associated with an increased likelihood of a diagnosis of an inherited platelet disorder. A significant proportion of patients with ITP will experience fatigue, which is not seen in inherited thrombocytopenia. In addition, morphological abnormalities of platelets other than a mild increase in platelet size suggest a genetic form, and the fluctuations in platelet counts are not as common in inherited platelet disorders as in ITP. Immune thrombocytopenia generally occurs in sporadic individuals. When we see ITP patients clustered in families, even those who may respond to some treatments for ITP, we should suspect an inherited form. For example, we described 4 adults from one family who were diagnosed with ITP, with immune thrombocytopenia, and treated with corticosteroids or underwent splenectomy with good platelet responses. They were found to be heterozygous for a germline gain of function variant of SARC. Similarly, other inherited thrombocytopenias that associate immunodeficiency or inflammatory manifestations, such as Wiskott-Aldrich syndrome or patients with RPC1B, may have a platelet response to some ITP treatments. The second block includes 13 forms of inherited thrombocytopenia that present with syndromic manifestations from an early age. In most cases, the diagnosis should be easier than in those presented with thrombocytopenia alone, but even today, the extra hematological manifestations associated with these conditions are often considered attributable to other disorders rather than integrated into a single disease. We will present some real cases to illustrate how late we suspect these conditions, and that such a diagnosis is unfortunately guided by an inefficient response to inappropriate treatments in many cases. So the first case is that of a boy who was referred to us at the age of 4 years. He presented with moderate thrombocytopenia since birth and had no relevant family history. A diagnosis of ITP was made, and he was treated with corticosteroids and also with IVIG, resulting in a moderate 2 to 3-fold increase in platelet count. He had a defective antibody response to hepatitis B vaccination and also increased tendency to respiratory infections, which was attributed to steroid treatment. The smear showed small platelets, and he carried a de novo hemizygous intronic mutation in WAS, which was confirmed by restriction analysis. The reduced WASP protein expression in various blood cell subtypes was detected by flow cytometry. And the patient was diagnosed with Wiskott-Aldrich syndrome and underwent allogeneic hematopoietic transplantation. Now, Wiskott-Aldrich syndrome is an almost exclusively male disorder with X-linked inheritance, presented with bleeding, ecthyma, autoimmune manifestations, immunodeficiency, and malignancy. Typically, severe disease occurs in those individuals with without functional WASP, without protein, and is associated with a very poor prognosis and short life expectancy. Allogeneic hematopoietic stem cell transplantation has become the gold standard treatment, and gene therapy, which is still experimental, is also a promising approach for patients without a suitable donor. So the next two cases are of two unrelated individuals from the same geographical area of Spain with a long history of ITP and palmoplantar and anogenital hyperkeratosis since early childhood. They were diagnosed with primary immune thrombocytopenia and treated with corticosteroids, and in patient one also with splenectomy with suboptimal results. Using whole exome sequencing, we identified compound heterozygosity for mutations in KDSR. So mutations in KDSR cause defects in ceramides, which are essential for signaling processes and for maintaining the integrity of membrane structures in the skin. And defects in platelet formation and release in the final stage of thrombopoiesis appear to be the primary cause of thrombocytopenia in these patients. And as in Wiskott-Aldrich syndrome, hematopoietic stem cell transplantation should be considered in cases of life-threatening bleeding. And now we come to the 11 forms of inherited thrombocytopenia, where the genetic defects responsible for thrombocytopenia also result in a predisposition to develop additional diseases over time, including hematopoietic malignancies and aplastic anemia. It is noteworthy that in many cases, these forms are associated with only mild thrombocytopenia. We should be aware of and recognize these types of conditions in part because of their prevalence. If we look at the casuistry of inherited thrombocytopenias from our working group in Spain, among the patients with definitive molecular diagnosis, 53% of them, those in gray, present only thrombocytopenia, followed by those with thrombocytopenia and a predisposition to additional disorders, which account for the 40%, which are those in red. And while those with only defects from birth are the minority, the syndromic forms are only 7%. The most common form of inherited thrombocytopenia that predisposes to additional disorders was present in a man who was diagnosed, again, with immune thrombocytopenia, with ITP, at the end of the second decade of life and treated unsuccessfully with steroids and splenectomy. At the age of 20, he developed sensorineural deafness and subsequently end-stage renal disease, requiring a kidney transplant in 2008. A careful peripheral blood examination was not performed because the neutrophilic inclusion bodies were not detected. The molecular study confirmed the patient's disease, and family screening revealed that 2 of his daughters were affected by it. This disorder, MYH9-related disease, is the most common inherited macrothrombocytopenia worldwide. It is caused by monoallelic mutations in MYH9, which is the gene that encodes for myosin heavy chain 2A. All patients present with thrombocytopenia and giant platelets at birth, and this is not a trivial disorder because 25% of the patients develop kidney disease, which in most cases progresses to end-stage renal disease requiring dialysis or kidney transplantation. And in addition, approximately 50% of the patients develop sensorineural deafness and 18% presenile cataracts. So the clinical course of MYH9 is quite heterogeneous, ranging from isolated and asymptomatic thrombocytopenia to a complex disorder that severely affects the quality of life. The next case is that of a 40-year-old man misdiagnosed, again with ITP, and treated with intravenous immunoglobulins and corticosteroids. And after several bone marrow examinations, he was diagnosed with refractory cytopenia with megakaryocytic dysplasia and 5% blast in the bone marrow. Bone marrow transplantation was considered, but molecular screening confirmed the presence of a de novo variant in heterozygosis in the ANKRD26 gene. As of 2016, the WHO classification of myeloid neoplasms and acute leukemias includes a category of disorders defined as myeloid neoplasms with germline mutations and pre-existing platelet disorders, which includes those with variants in the RANKS1, ANKRD26, and ETV6 genes. These are three autosomal dominant disorders with normal mean platelet volume, and together they account for more than 1/4 of the prevalence of inherited thrombocytopenias. The development of hematological malignancies, mostly myeloid, occurs in approximately 48% of patients with germline mutations in RANKS1 and in 7% of patients with ANKRD26. Around 1/5 of the patients with ETV6 will develop lymphoid malignancies. And although thrombocytopenia, if present, is detected at birth, some patients have platelet counts at the lower end of the normal range, and the development of malignancies usually occurs between the 2nd and the 5th decade of life. So in addition to the propensity to develop hematological malignancies, thrombocytopenias due to germline mutations in RANKS1, ETV6, and ANKRD26 share many other relevant features, such as an autosomal dominant inheritance pattern, mild to moderate thrombocytopenia, and normal or near normal platelet size. And it is very important to perform family screening once a case is identified, especially if the patient is a candidate for allotransplantation from a related donor. Next case is a 24-year-old patient previously diagnosed with ITP and treated with steroids and splenectomy. He later developed severe neutropenia, and a bone marrow examination showed decreased cellularity and megakaryocyte count in addition to monosomy 7. The molecular diagnosis identified a homozygous variant in the thrombopoietin receptor. The patient underwent bone marrow transplantation from an unrelated donor and achieved a complete resolution of all lineages. So biallelic mutations in MPL, which is the gene encoding for the thrombopoietin receptor, cause congenital megakaryocytic thrombocytopenia, which presents at birth as isolated hypomegakaryocytic thrombocytopenia. Patients develop additional cytopenias during childhood, eventually progressing to aplastic anemia. Biallelic mutations in the thrombopoietin gene have a similar presentation, but in these latter cases, the administration of thrombopoietic agents induces trilineal hematopoietic responses. But if the defect affects the TPO receptor, the curative treatment should be allogenic transplantation. The next case is that of a man who was referred to us at the age of 28 for moderate thrombocytopenia. He had a history of sensorineural hearing loss since childhood, which was considered secondary to ototoxic drugs. He had 2 children, both with thrombocytopenia, neutropenia, and deafness. And the complete exome sequencing revealed a mutation in DIAF1 in the 3 members of this family. DIAF1-related thrombocytopenia is an autosomal dominant disorder with variable macrothrombocytopenia and neutropenia, with onset of hearing loss in the first decade of life, much younger than MYH9, and TPO-RA may allow the correction of platelet counts before elective procedures. The last case is that of a 46-year-old woman from Salamanca with long-standing macrothrombocytopenia and multiple palpebral surgeries for xanthelasmas. Peripheral blood smears showed abnormally shaped red blood cells and giant platelets, and the molecular analysis identified new compound heterozygous variants in 2 exons of the ABCG5 gene. Cytosterolemia is a rare autosomal recessive storage disorder that is characterized by elevated plasma plant sterol levels caused by pathogenic recessive variants in the ABCG5 and or ABCG8 genes. And clinical features generally include skin and tendon xanthomas, premature coronary atherosclerosis, arthritis, or arthralgia. And the hematological abnormalities include hemolytic anemia, stomatocytosis, macrothrombocytopenia, and splenomegaly may also be present. Ezetimibe reduces the atherogenic lipid profile, but as shown in the patient's case, may be associated with an increase in the platelet count. And the diagnostic delay of decades may lead to subsequent risk of advanced atherosclerotic cardiovascular disease. So these cases highlight that despite thrombocytopenia being present from birth, most patients were not diagnosed until the second or subsequent decades of life. Inherited thrombocytopenia should be suspected when several members of the family are affected or when the decrease in the platelet count has been documented since birth. In practice, in many cases, thrombocytopenia may be an incidental finding discovered in adulthood, leading to a misdiagnosis of immune thrombocytopenia, and the absence of a family history may be frequent, either because the inheritance of the condition is recessive or because of the novel mutations. This has been documented in up to 35% of patients with MYH9. And in addition, the penetrance of the causative mutation may be incomplete. And although a lifetime of bleeding should raise red flags, most patients present with little or with no bleeding tendency. So just as we consider ITP to be a diagnosis of exclusion, we should also contemplate inherited thrombocytopenia in a patient when there is no previous evidence of a normal platelet count. And in part, this is important to recognize because we had to offer the patients the best available treatment. Most individuals with MYH9 or Wiskott-Aldrich syndrome respond adequately to thrombopoietin receptor agonists, which should be considered for elective surgery or other invasive procedures. Thrombopoietic agents are also a choice in inherited thrombocytopenia due to biallelic mutations in the TPO gene. Patients with MYH9, especially those with mutations most commonly associated with renal failure, cataracts, or hearing loss, are advised to have regular checkups and consider the need for treatment to restore the function of these organs. In inherited thrombocytopenias with a predisposition for hematological malignancies or for aplastic anemia, bone marrow examination and regular CBC and clinical evaluation may be recommended. And if allogeneic progenitor transplantation is considered, it is essential to exclude that the donor has the same molecular defect. So the cases presented here are intended to show a reality that we must change: the delay in the diagnosis of inherited thrombocytopenia. The manifestations of these illustrative cases include immunodeficiency, hearing loss, renal disease, accelerated vascular disease, aplastic anemia, skin keratosis, and predisposition to hematological malignancies. So with that, I would like to thank you for your attention, and we'll be happy to answer any questions that you may have. I leave the take-home messages here on the screen, and you can access them in the PDF that will be distributed. Thank you.
Thank you very much, Professor Lozano, for this great presentation. I can see we already have a few questions in the chat. Are you able to access them?
Yes, yes, let me see. So the first question is, what do you recommend in terms of follow-up? What do you recommend, or when do you recommend TPORA's use? Starting at the end, I would recommend TPORA use in those disorders where TPORAs have already been shown to be effective, such as mainly Wiskott-Aldrich, MYH9, and also DIAF1. It's useless to use this kind of agents when there is a functional defect, a relatively important functional defects in platelets, since increasing the number of dysfunctional platelets will not improve the hemostasis. Right now, there is no evidence that using these agents in inherited thrombocytopenias that may predispose to hematological malignancies cause this problem. Only 10 patients with ANCAR D26 have been treated with TPORAs, but so far no problem has been detected. So I think they are completely safe for the short term to prepare mainly for surgeries, but they can be also a very good agent if in those patients that have significant bleeding, especially those MYH9 patients that have seen very low platelet counts and significant bleeding for long-term use. They will be always off-label because we will not have enough clinical good data to be approved by the regulatory agencies, but they are more and more being introduced in the clinical setting for the treatment of these patients. And in terms of the follow-up, it depends on what kind of inherited platelet disorder we are facing. The most dreaded one, which are the ones that predispose to hematological malignancies, it is mandatory to perform a bone marrow examination at basal state once the disease is diagnosed, and then at least once or twice a year to perform regular checkups in terms of clinical evaluation and biological evaluation, mostly CBCs and blood smear. It is important to test family members because the penetrance, especially in rank S1, is very incomplete, and we can have carriers of these variants that can be pathogenic with normal platelet counts. So in case we detect also a carrier in the family that has this mutation, the same follow-up has to be done. In other cases, like in those predisposing to aplastic anemia, especially congenital and megakaryocytic thrombocytopenia, we know that in the great majority of the patients will need allogeneic hematopoietic transplantation. So I will try, especially if it's a non-pathogenic variant, to perform the transplantation as soon as possible, as in Wiskott-Aldrich, before the age of 5 years, because the the complications following allogenic transplantation, and the efficacy of this procedure is much better when the patient is under this age. In those forms that only have mild thrombocytopenia, non-important bleeding, probably seeing the patient once a year is more than enough. So it depends very much on the kind of inherited thrombocytopenia. The following question is regarding emerging diseases. Did you include SAMD9 or SAMD9L in your panel, and did you diagnose this disease in patients with isolated thrombocytopenia? We don't have SAMD9 still included in our panel, but I think yeah, we had to continuously revise the panels of the genes that we are testing. This is a question that probably pushes most of us to go to exome sequencing. We will have that data, and still we cannot diagnose 50% of the patients with inherited thrombocytopenia, especially those that don't have a specific presentation. But if we try to move to exome sequencing, now the cost is very similar to panels, we will have those data, and we can go back to those data as these new disorders are being described. So that is a limitation with the panel of genes. We cannot be continuously changing the panel of genes every 2 months, every time a new disease is diagnosed. So as some IPDs may be associated with response to ITP therapy, would you recommend genetic workup in all patients with chronic ITP? Now, right now, ITP is probably has a genetic predisposition, but there are many factors here that lead to the development of this disorder. There is a clear genetic factor predisposing to the development of ITP in those patients, especially pediatric patients with primary immune deficiency, those patients with Evans syndrome, or those with other autoimmune manifestations. But right now, all the tests that have been, every time that we have tried to dissect the specific genes for ITP, the results have been unsuccessful because of this. So, but selecting probably patients with a specific profile, refractory patients that have ITP but are refractory, maybe we can see specific genes, maybe not so much related to inherited platelet disorders, but maybe related to immune deficiencies, to how lymphocytes, T lymphocytes are working. And so probably there is a subset of patients that we can try to develop in the future this kind of testing. So the next question is how regular marrow testing could be useful in inherited thrombocytopenia with predisposition to leukemia. I think it's necessary to perform the bone marrow analysis and cytogenetic analysis. It seems that these conditions, we don't find the second hit in this condition that predisposes those patients to the development, or at least we don't identify it, of leukemia. And I would do regular checkup, as we said, but just with CBC. I think just performing annual bone marrow examination, I would not recommend unless there are flags that raise our suspicion in terms of changes in the peripheral blood counts. So just basal, and depending on the follow-up of the patient, decide if there is a decrease in other cell subsets or increase in thrombocytopenia. Of course, go and recheck the bone marrow, but not routinely on a regular basis. There is another question before the genetic workup. What exhaustive workup, biology, imaging do you recommend to detect familial thrombocytopenia. This depends in many groups. We have moved in 15 years from recommendations of genetic testing in many cases being unnecessary or being relegated to the last step of the diagnosis of inherited thrombocytopenia, to now that they are introduced every time earlier and earlier. I think I don't agree with those design of diagnosis that, okay, I have a suspicion of inherited thrombocytopenia. The first step is perform high throughput sequencing. I think that other than doing a very detailed history, personal and family history, we have to use all the available tests that we have, that we are familiar, that we know what kind of information and how useful it can be before moving to high throughput sequencing. It is clear that the diagnostic success of high throughput sequencing depends very much on how the patient is initially evaluated. So maybe it doesn't have any, in those cases with inherited thrombocytopenia alone, with no bleeding whatsoever, that we can anticipate that the platelet function is going to be normal. Maybe it doesn't make sense, but I still would recommend to use basic tests, flow cytometry, arterigometry, before moving to the sequencing panel. Of course, after we identify a variant especially if it's a new novel variant, we have to go back in the other direction and validate that variant using the specific test that we have even, I don't know, cellular models, animal models. Of course, segregation in the family, that is a must every time we identify a novel variant. But I would recommend after the suspicion, the clinical suspicion, to perform the test that we have, that we are familiar with, that we know that we use them and we know what kind of results and how useful they can be before moving to genetic testing. So there is another question. Do you propose bone marrow transplantation for all WAS, especially X-linked thrombocytopenia mutations without severe infection? No, I think here the immunologist and usually pediatricians had to perform the score. I don't remember. I think if a score is greater than 4, it would suggest that the patient should go to allogenic transplantation. So for X-linked thrombocytopenia, these are mutations, that hypomorphic mutations, that is, the protein is still present in the blood cell subsets at lower levels, but it's still present, and the course of the disease is much more benign than those with typical or classical Wiskott-Aldrich syndrome. So a very careful evaluation in terms of how the protein is expressed, the clinical manifestation of the patient, what kind of mutation the patient has, before recommending allogenic transplantation. Another question is, what about real clinical ITP evolving to chronic forms which harbor genetic variants of unknown significance in genes associated to genetic thrombocytopenias? Well, this one is difficult. Yeah, it has been seen also with one of the predictors of chronic ITP is the chronicity. As ITP becomes more chronic, is sometimes there is a selection of clones that become very resistant to ITP treatments. And it has been seen that these clones can acquire specific somatic mutations in TET2, in TET2 and in other genes that can associate with myelodysplasia or even in RANKS1. So what do I consider? I would just do a regular follow-up of those patients, but this question has all the meaning and all the significance that we had to perform very close follow-up of these patients when we detect the acquisition of these somatic mutations in patients with refractory and chronic that were real ITP because they responded and they had a clinical typical course of ITP, but sometimes they acquire this kind of mutations and become really refractory. I would recommend close follow-up and that's it in case a novel disease is developed, myelodysplasia, myelodysplastic syndrome or whatever, then just continue the clinical management of the patient according to the new disease. So there is another question. Is there a notion of positive antiplatelet autoantibodies in bona fide constitutional thrombocytopenia, in actinium, tubulin, excluding primary immune deficiency associated causes such as was of others? Not that I know of. Maybe there are, but know that I know of. Of course, when patients are exposed to platelet transfusion, these antiplatelet antibodies are developed, but I assume that this is not a question. But I think the pathophysiology of these disorders is a defect in the cytoskeleton that justifies the defect in proplatelet and platelet release. Whether there is antiplatelet antibodies that can contribute to it, I'm not aware of. And here there is another comment regarding genetic testing that we cannot disregard the ethical issues of genetic testing. Yes, that is an important issue. And let me see. I think that is it. No more questions.
That was the last question. Thank you. Oh, we have one more question.
Sorry. I meant germline variants in genes like 2B3A, tubulin, or GP1B, alpha or beta. This is a case I have already. Germline variants. Germline variants with in genes that there are receptors for the in the membrane of the platelets. So I imagine, there is also tubulin one, but I imagine this, if there is a defect in the synthesis of these receptors, these antibodies can be developed when the patient is exposed to other receptors from normal platelets following platelet transfusion. There are also cases of immune thrombocytopenia that have excessive bleeding with antibodies that are directed to these important receptors, but we don't find germline variants there. But I'm sorry, Paula, but I cannot help you with this because I have no idea. Thank you.
Thank you very much again, Professor Lozano, for this great talk. Thank you everyone for being here tonight and asking all these questions. We hope you had a great time with us, and we want to invite you to join us on the next session as well on this topic on focus, which will happen on the 15th of November by Professor Andreas Greinacher. Thank you again so very much, Professor Lozano. Thank you everyone for being here, and we wish you a pleasant evening. Goodbye, everyone.
Thank you and goodbye.